Paediatric Trauma Q&A with us. Basically, the whole objective of tonight is to help you be kid confident and manage trauma in children more confidently. So as you can see from my cheeky little t-shirt there, children are small adults in the context of major trauma, and that gives you the permission, I guess, and the ability to treat children as well as you treat adults in these situations. We all know that it's a really small amount of your workload compared to adult trauma, and hopefully the idea of tonight is that you will see that the principles of treating children are the same as they are adults. So children do a little bit worse than adults in terms of major trauma, and the reason for this is because they have missed injuries, and that's usually the fault of hospitals because they have a high threshold for CT imaging and they don't always tell you everything, and that can be a bit of a problem. We're all guilty of under resuscitation of children, and they get coagulopathies, and then when they get to hospital, the paediatricians and the trauma doctors like to argue with each other instead of getting on with treating children. So they're treated a little bit like an alien species. Brings me on to a rant, which is boring for some people because they've heard it before, but I'm going to do it again. And this rant is that the message we're told is children are not small adults and that they look like this, and we should all be very, very afraid of sick children. And that is quite frustrating for me because I know that when I see children, I think they are a bit like small adults, and there are some important differences, but we really shouldn't be scared by them. And when it all goes wrong and we're dealing with trauma or resuscitation, we wouldn't go far wrong by scaling adult care to size, and that would make a massive difference. But what are the differences between adults and children? They might have different mechanisms of injuries because their body proportions are different. We're obsessed with calculating everything based on their age and their weight, and that's fluid, blood, drugs and everything else. We have this wet flag preparation. Their normal values are different and they compensate until they crash, and that's something that the paediatricians love telling us. But what they don't say is when they crash, you can usually get them compensating again quite quickly, and that's something I want you to all bear in mind. Obviously, these calculating body weight can be really difficult because all the calculations start off with a child's age, and you might not know the child's age, especially if they're out in the streets and they've just had an accident. There's nobody around there to tell you. So something that I like to do and tell people about is to go on their clothes age. So most children's clothes have age range in them, and if you just have a quick look in the label of their clothes, it'll say age whatever, and you can use that as a basis of your calculations, and that works really well. The little ninja in the middle of the poster there, this is the first KidConfident poster. That it is my joke, and when we took that picture he was 6 years old, and when you calculated his weight according to APLS formula, it comes up with 25 kilos. But he's quite a big lad, so his clothes age is 8 years old. He wears 8-year-old clothes, and that calculates his body weight at 31 kilos according to APLS, and when you stick him on the scales he was 30 kilos. So you can see there how under resuscitation comes into play, because we would be resuscitating him with drugs, blood and fluids based around 25 kilos, where actually he needs a little bit more than that. So using a clothes age can be a really good way to start all your calculations and give accurate amounts of drugs and blood and fluid and everything else. Awesome. Going along with all these calculations, it's difficult to remember all the different doses and calculations for these children. So using aid memoirs like this one here, which is available for free on the KidConfident website, can help you do that. And having something that tells you the doses to give after you've calculated their weight based on their clothes age can be really, really helpful. I use these all the time as well. I've got no shame in saying that. I'm a paediatric anaesthetist and I give drugs all day, but I will still look at my aid memoirs to help me remember to give the right amount. And then they have normal values are different as well, because as they grow, their heart rate slows down, their blood pressure goes up and their respiratory rate goes down, and that is something I can never remember despite how many times I'll try to learn them. So having aid memoirs, again, something with your normal ranges on it, can also help you when you are looking after these children. If you're a paramedic, obviously you've got access to the JR Calc Plus, and that's really good app on your phone. You can just go for page per age and you put in the kid's age and it will give you all the normal values and all the drug doses, and I just think that's amazing. So definitely you should make use of that app, which you should have free with you. If you don't work for an NHS trust and you don't have JR Calc on your phone, then there are some freebies on the website, but also there's other options like kid cards. Or we like kid cards because my mate made them. So if you want to buy kid cards, go to the website kidcards.co.uk, and if you put in the discount code KID10 at checkout, you will get 10% discount. But that has got all the normal values and the drugs as well, so you can give accurate doses of everything, and you can see on the monitor is normal and you don't have to remember anything. And I think that's really important. So how do we approach paediatric trauma? It's the same as we do for adult trauma. It's the CABCD approach: catastrophic hemorrhage and the airway, breathing, circulation, disability and exposure. The same as you would do for any other trauma patient who's not a child. The things that you really want to find and treat during the pre-hospital primary survey, which are immediately life-threatening, things like your airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest and your catastrophic hemorrhage. And you can remember that with the acronym ATOM-FC, which is straight out of ATLS, and it applies to children and it applies to adults as well. And you will find all these things doing your primary survey and be able to treat them as well, because you know how to do that already. When they are really sick and they either arrest or they're about to arrest, then you obviously look at your hot approach, the same as you do in adults, and that's your hypovolemia, oxygenation, tension pneumothorax and your tamponade. Obviously we can treat hypovolemia by controlling hemorrhage, by applying pressure, packing wounds, using tourniquets and binders. You want to get some large bore IV access or IO access and give a fluid challenge. Now the fluid boluses have changed over the years. It used to be 20 mils per kilo. Now we advocate giving 10 mils per kilo. And in trauma, it's now advocated that you give 5 mils per kilo because of the same principles of resuscitation in trauma for adults, is you don't want to blow off any clots. If you have access to blood because you're in an enhanced care team or a critical care team, then obviously give blood, because that's a really good thing to give to people who are bleeding. These pictures of one of the posters on the website, one of the recent ones that one of the CCPs at the Air Ambulance Service did for us, and it just describes the hot approach and the management of traumatic cardiac arrest in children. So make sure that you have a look on the website and have a look at that if you want. Oxygenation, you know how to manage that. It's the same: suction, clear the airway, give some breaths and use airway adjuncts, eye gels, and make sure you're measuring your end tidal CO2 so that you can see when their cardiac output changes or if they stop bleeding. Needle decompression of a tension pneumothorax, you can use the same landmarks as you do in adults, the second intercostal space in the midclavicular line, and it doesn't really matter what size needle you use. That is a question that people often ask, is do I have to use a smaller cannula for children as I do in adults? And actually I don't think it really matters. The bigger the cannula that you use, the quicker you'll decompress a tension pneumothorax. But if you use a small cannula, then you'll still decompress it. It'll just be a smaller rate, a smaller flow rate. And then cardiac tamponade is something obviously day-to-day paramedics won't be able to manage themselves, but that's when you're starting to make decisions about moving from scene to get to a hospital or getting an enhanced care team or critical care team with you to perform a thoracotomy. They are still indicated in children, the same as they are in adults, and it's important that these things are done. Personally, I think as a parent myself that if my lad had an injury where he had a tamponade and it could be relieved with a thoracotomy, I would want somebody to try. And this sort of brings you
sorry, just to stop your flow there slightly. Shannon's just asked a question. So, applying a pelvic binder in children, can it be done? In answer to that, absolutely yes, because in the context of trauma, we're doing everything the same as we would in an adult, and this is the key take-home message, I think. So Shannon, yes, you can. If you need to reduce the pelvic fracture, if you get to a patient and you've got that splayed open book fracture, then absolutely we need to close that down in order to reduce the space of which the bleeding can happen into.
It's a good question actually, because especially in the smaller children, pelvic binders don't fit really well, and depending on the type of binder your service uses, you can cut them down. So if you've got the Prometheus ones, you can cut them into like a thinner belt and apply them, but you can't really do that with a Sam Splint or a T-Pod. But you can improvise pelvic binders, so you can use sheets and towels, blankets, whatever you want. And if they're really small and you're worried about a pelvic fracture, then you can just tie their knees and their ankles together, and that does exactly the same thing as putting a binder on. Gavin saying APLS would suggest the safe triangle for decompression of a tension pneumothorax. You can use that as a landmark. We would, in the HEMS team, we will do a thoracostomy in the safe triangle just because it's more effective than putting a needle in. So there is no reason why you couldn't put a needle in the safe triangle to decompress the tension pneumothorax in a child. Practically speaking, I think the anterior landmarks, like the second intercostal space, is a bit easier to do sometimes, but yeah, there's no reason why you can't use the safe triangle either. And that's something that's contested by some people, and everyone has their own opinion of that, which just really goes to show that there's no right or wrong answer, absolutely. And you get the same arguments in adults as you do in children, whether you should decompress anteriorly or in the safe triangle laterally. Basically, the important thing is that you need to get air out of the wrong spaces in the chest, and any way that you achieve that is fine. Hope that helps.
And so regarding just needle decompression, I think, just if I could add, people are sometimes scared about, the size of the cannula that you're going to use for accessing the child is not the size of the needle that you're going to use to decompress the chest. So as large a needle as possible, particularly in trauma, to try and get that air out. And it's falling out of favour in hospital medicine now, isn't it? And thoracostomies are the first thing to do rather than needle decompression. But if you're out there and that's all you've got, then I just say use a large needle.
Yeah, I'd go with that. Use what you've got, and don't stress about needle size. Cool. Oh, there's a little QR code on the bottom of this for Stop the Bleed tutorial. It was done with the American College of Surgeons, and it's related to paramedics. It's a good refresher for management of catastrophic hemorrhage in patients of all ages. So that's there. One thing that I think is important with all critically ill children is to get away from this scoop and run mantra with sick children, is that you scoop them up and take them to the nearest hospital without addressing their reversible causes of cardiac arrest. That doesn't really do them any favours. So I think you should always try and address what you can on scene as best you can before moving to a children's major trauma centre. But if they're really in extremis and you're a long way from help, or help's a long way from you, then the nearest hospital is better than nothing. There's some resources available on KidConfident website, which is really, really helpful, I find. There's a Paediatric blast injury field manual, which is originally written for paediatric trauma in conflict zones, and it covers all phases of care from pre-hospital phase to recovery. But the pre-hospital phase chapter really does give you some good knowledge and understanding of approaching children with traumatic injuries of all types. We've also got this quick guide, Emergency Pain Management for Injured Children, which again was written with the blast injury group for conflict zones, but it's got some really good tips in there for managing pain at all levels in children, using a specific approach. It's completely free to download. Both of these things are completely free to download, so please feel free to visit the website, download them and have a look. They've got loads of useful information in them, and the pain management guide even has drug dose tables and stuff in there for you as well, along with a load of other resources. Do we want to do a case study? I think maybe we'll do a case study. We're not getting loads of questions through. So one question we did get, actually, before we do this, we did get one question about when it would be appropriate to stop resuscitation in a child and when it would be considered futile. This is covered in JR Calc, and it's in the app, and it's got the conditions unequivocally associated with death in children. So to answer the question that was left in the comments before this started, the reasons that you would say that resuscitating a child who's suffered traumatic injuries is futile and you would either not start or you would stop are decapitation, massive cranial destruction, hemicorporectomy, evidence of decomposition of the body where tissue damage shows that the patient's been dead for some hours, days or longer, full thickness burns and incineration, so greater than 95% of the body surface area, pooling of blood in congested vessels in the dependent parts of the body, rigor mortis, and fetal maceration in a newborn. So they are the only reasons that you would not commence resuscitation in a child. In all other cases, you should even if you think it's futile, you should resuscitate and transport them to hospital. If nothing else, it gives the parents some closure and some understanding that everything was done for the child and that everyone did make an effort. And for your own well-being as well, you know that even though it appeared to be futile, you've done your best to try and help them out, really. And looking after yourself is really important, and having your own peace of mind that you've done everything possible for a child who's injured is really important, because it is quite emotive looking after really badly injured children. So I hope that answers that question that was asked in the comments beforehand. I'm going to go through this quick case study where a 2-year-old pulled a concrete mantelpiece down off the wall onto themselves. They were found to have bruising to their back and their chest wall. They had low sats, high rest rate despite oxygen, and they had an increased heart rate of 170 a minute, but they were still alert and crying when the original crew got there. So what would your plan be for this?
Stick in the comments what their initial thoughts are. That'll be quite interesting, just to get a feel.
Yeah, I think, Gavin, you've got a good point. 4 H's and T's excluded should always be done, and your hot causes should be addressed in traumatic arrest. I think it's right not to go on for too long, but just as long as you know that you've done everything that's needed for that child, then that's acceptable. Nobody would criticise you, though, for continuing resuscitation for longer and taking them to hospital for them to stop, because it's quite a decision. And as Kelly says, it is quite hard to not start resuscitation on a child, and it is hard to call it as well. So with a case study, you'd go through your primary survey, your CABCD approach, and when you've assessed the child, these are the findings that you find. If you've got any ideas about what your priorities would be and what you would like to do in terms of intervention, leave them in the comments below and we can talk through them. Yeah, Addy, I like that. Hot. I would definitely be thinking about those things. He's very sick, isn't he? Doctors are the worst. You need a good resource officer. I like that, Gavin, yeah. I shouldn't say that, though, being a doctor, should I, really? Never mind. We can take the blame for stuff, though, so I think my initial interventions for this child would be to provide high flow oxygen, obtain some vascular access, and if I was on my own, I would be asking for enhanced care and critical care, because I think this child's showing signs that they need some volume resuscitation, really tachycardic, tachypneic. Kelly wants to decompress the chest. I think that's a reasonable thing to say, because there are signs that there's respiratory distress, as you can see from here. You've got some quiet air entry, and you've got low sats and a high respiratory rate. Roger wants to give bilateral IV access. We like that. If they're clapped out, you could go for IO access. APLS says have 2 attempts and then crack on with the drill. And we spoke about having a pelvic binder, and tranexamic acid wouldn't be an unreasonable thing to give in a patient you think is bleeding either. I think we're all good with that, aren't we? So you do all those things and then it all goes a bit quiet. Yeah, IO on a conscious child is a bit tricky, Addy. Yeah, I can go with that. But you know, if they're this clapped out, then I think you can get away with it. Obtaining the IO access isn't the hard bit. It's when you push fluids through it. That's when it gets really difficult. There are some challenges of extrication, especially with this picture. I don't think it would be as dramatic as this, though. This is an AI generated cluster. So you do all those good things. You manage to get some cannulas in, shall we say, and then it all goes a bit quiet. You go through your CABC again, and you can't get a SATS trace. They're not breathing. You can feel some surgical emphysema, despite decompressing the chest. You've got lots of bruising over the chest, but their heart rate's dropped. BP's unrecordable, but their capillary refill time is increased. They're unresponsive, and they've got some bruising to the chest, as we've said. Roger, I've got no idea how long it's going to take for IMTXA to be sorted. Steve, crush injury. We don't know how long they've been trapped, but I think that in this circumstance, they were alert when we got there and they were crying, so they were conscious to some sort of level. Would you decompress the chest on a child who is alert? Yeah, I think I would do, because if you've got signs of tension pneumothorax and they're struggling, it's not going to be long until it all goes quiet and they're not conscious anymore. So the same as you would do in an adult, say sorry and stick a needle in. And it seems a bit heartless, but yeah.
And I think there's a really good point here, James, because I think we've often got that sort of black and white, very black and white scheme, that a doctor is a doctor and a paramedic's a paramedic. And for doctors to say, yeah, that's fine, we'll go ahead and decompress the chest on a child, is quite a ballsy move sometimes, I think, for paramedics particularly, but at the same time, it has to be done, because this is only going to end up going one way. If they've got a pneumothorax which is starting to tension, then you need to prevent that tension, because that's what's going to prevent that deterioration. So it's very difficult. And I think people just need to get more comfortable with the concepts sometimes. So that's exactly what this is sort of designed to do, isn't it? It's to talk around the possibilities that one day you may well be first on scene to this. There could be an extended amount of time before the enhanced care or the critical care team are arriving, and you actually have to be the one to make this decision. So these questions and statements are all really relevant.
Yeah, I'd have to go with that. It is easy for me to say, yeah, stick a needle in, blah blah blah, but yeah, it might not be as easy a decision when you're faced with it on the scene. Pain relief for a chest injury, I think, is totally appropriate before it all goes quiet. When it's all gone quiet, then I wouldn't worry about the pain relief. But definitely, I think that's a really good shout. Thank you, Jutta. David's saying, would you get fire or heart for extrication? Well, if it was this scene, then I think you would have to, wouldn't you? But if it's just a normal mantelpiece that you can lift yourself, you can lift it yourself, and that's good. AD as an NQP, this is terrifying. Yeah, you know what it is, and it's terrifying for me as a doctor, even doing HEMS. But like the ninjas, you train hard and fight easy. So if you can mentally prepare yourself for this sort of horrific scenario, then anything else is easier after that. So I'm sorry, I hope I'm not putting you off. It is worth saying that this sort of thing is really, really rare, and there is help available. So you would obviously at this scene call for some backup, some enhanced care or critical care teams to come, and they would come and support you with that as well. Jean has said that you consider moving towards critical care team whilst treating. Yeah, that's a really good point as well. So you, rather than waiting there, if you've got them free, obviously, you can plan a rendezvous and start moving towards trauma centre or hospital, and having the critical care team meet you en route. That's a really nice thought. Kelly's never been taught decompression on kids, but you were taught on adults, and it's exactly the same. So that's their get out clause, I think, for not specifically doing it on children. And yeah, it is you just treat them like an adult. That's what I do. Derek is probably like spitting feathers because he's a paediatrician and he's like,
not at all. No, I completely agree. I think just to sort of put a few comments. It's often the hardest thing is to make a decision to do something. And that's what Gareth is saying as well. Just sort of, if you can see that that's a problem, then, and what you're saying, if you've got the skills to do that, and that if that's needle decompression, then you do that. And if they're awake, then that's better doing that while they're awake than waiting until they go quiet. So it is tough. But I think that's in my experience, when you're doing things like IOs and wake children or painful procedures, they're in a lot of pain and distracted by a lot of other stuff. So actually they do put up with it quite well.
Is it worth maybe as well, just while we're on the subject of thoracic trauma, just going through the sort of basics of understanding it, and then doing a very quick primary trauma survey, particularly around the chest, as we're talking about putting needles in, etc. So I think thoracic trauma, with your blunt, your penetrating injuries, majority of the time, just simple procedures are required. And they are simple, but they're really daunting to people who aren't used to doing it. And this is possibly a one in a career sort of event when you roll out to something like this. And as James has said as well, the chances of you being on scene on your own for very long is highly unlikely, because the ambulance service will do everything they can to hoof everything out to it. Minority require urgent surgical exploration. That's the other good news. You know, if you can see it, it's probably happening. And repeated serial examination is definitely what is required. So you need to constantly be going back and hitting your assessment every time, because these things do change really quickly. So when it comes to your primary survey, it's good to just have a quick look at the chest, see what the respirate's doing. You know, particularly kids, they're going to be tachypneic, so they're going to be gagging for air. As that tiny little space in their chest is starting to tighten up, then they're going to become tachypneic very quickly and likely hypoxic. So good coma, so access and close off oxygenation and monitoring on to get that as quickly as you can. We then need to be checking for the wall, the asymmetry of the chest wall, to see what bits are rising. Is it going up and down on both sides? You know, have they got paradoxical movement? Is there bruising around? Is there any sort of swelling or unusual looking signs? Have a look for tracheal deviation. That's key as well for definitely the sort of latter stage of the tension pneumothoraces. Have a quick feel if they are awake. Kids don't necessarily tell you that they're in pain, but if you start to sort of press and feel, then you may well get some wincing or some increased crying. Then we're going to be checking out for the surgical emphysema and just actually seeing if there's any sort of bubbling or that horrible crisp wallpaper feeling if you're feeling around. And we need to doing a 360 close off proper examination. And then obviously the auscultation, the listening to the breath sounds, so as best you can, and make sure you do it on both sides and also posterior and anteriorly as well. And if you get the opportunity, percuss for that resonance as well. That's the key.
Yeah, cheers, Gareth. No, that's cool. That's cool. Go on, Derek.
So yeah, I mean, I think the hardest thing to think about, particularly in this case, you've got sort of like loads of potential, problems with the lungs, but also with vascular and bleeding as well, haven't you? So it's, I'm going to talk about this in a little bit, but looking at the child and just looking at what they look like when they are. Do they look really shocked? Do they look really pale? What's their consciousness like? And looking at their work of breathing and how they're working. How you can often look at a child and work out how hard they're breathing just by looking at them without looking at them. So what Gareth said about stripping off is so important. You know, obviously we need to keep them warm as we can, but you know, you can get a lot of information just by looking at that child and working out what your priorities are from that.
Yeah, thank you guys. Thank you. That's all really good points. We've had a few more questions come up actually on the group. We've had Jean's asked, what would your first choice of pain relief be? So there's the analgesic ladder, isn't there? Starting off with paracetamol and then moving on to your opiates, NSAIDs, opiates, and then if you've got enhanced care skills, then you might be considering ketamine. I think the simple stuff like paracetamol and brufen, generally speaking, are underrated, but they are effective methods of analgesia. Obviously for somebody who's as injured as severely as this, then you would be thinking of giving some opiates, so you'd be giving some morphine intravenously or intraosseous, and that would be perfect. But I would also follow up with some paracetamol, because that will reduce the amount of morphine you need to give them. And even though you might feel that giving paracetamol for somebody with severe chest injuries is suboptimal or is not as effective pain relief as you would like to give them, actually using it as an adjunct to stronger analgesia is really, really effective. And I think that's a really important thing to do as well. Give everything you can. So my first choice for this child would probably be morphine, but I would definitely be giving some IV paracetamol for it as well. Gavin said, yeah, remember the little ones do have very springy chests, so that is true. They also can get some severe injuries though still, so you can be reassured that they might be less severely injured than an adult who's been in the same mechanism, same sort of problem, but they can still get chest injuries the same as anyone else can. George Duffin has seen this. Yeah, you have. Jota is saying he'd give some IV paracetamol. Yeah, and I think that's reasonable. Kelly's saying, would you give the IV paracetamol because morphine may drop the resps? It might drop the resps, but it might also improve their ability to ventilate properly. So a lot of the time people with chest injuries don't breathe properly because it's too painful. So giving some stronger pain relief, even though it is got a side effect of reducing the respiratory drive, can actually improve their ventilation and make them breathe better. So it's a bit of a backwards logic, but it does work. Yeah, we do forget the option of IM opiates as well. And if you've got limited access to get vascular access or IO access, then IM opiates are a good thing to go for as well. Roger's backed me up there with the morphine and the paracetamol. We like that. Intranasal opiates, Gavin, check you out. Yeah, so that's a really good option. Obviously, that can be limited by paramedics' scope of practice, and not all services have intranasal devices or support the use of intranasal opiates. But yeah, no, that is a really good option. If you are allowed to give intranasal opiates and you don't have a device, a little trick is to just get a pink cannula and chop it down and stick that on the end of a small syringe, measure out your dose and leave and add an extra 0.1 mils for dead space, and you can squirt that up someone's nose as well. So that works quite well. Gavin he's come out with some really good points, David. Just teacher's pet. He hasn't given me an apple yet, so we can't really qualify that. If he sends some stars though, fine. So there was some really good discussion there. Thank you guys, appreciate it, really appreciate it. I'm going to move on through the scenario though, where it does go all quiet and there's no sats trace, there's no respiratory effort. The heart rate is dropped, which is something to watch out for in kids, because often in adults, when we see a heart rate drop, we think we're getting on top of things. But in children, their physiological response to hypoxia and reduction in cardiac output is actually to slow down. So that can be a sign that things are not going the way that we want them to be going. Capillary refill time is an amazing monitor for children. It's more reliable than blood pressure and it's easier to obtain as well. So if you see the capillary refill time increasing, then that is a sign that they're bleeding and that they need some more volume. So in this child, in this case, the heart rate dropped, he stopped breathing and there was no palpable pulses. So he's gone into cardiac arrest and he's stopped crying. All the rest of your findings are the same. Kelly's saying crashing, get a BVM on him. Absolutely, I would definitely do that. And you would now, at this time, be focusing on your HOT principles, wouldn't you, on your HOT approach, so that you would define this with lack of palpable pulses. This is a cardiac arrest and it's due to trauma. So you need to be focusing on your hypovolemia, getting oxygen in with your BVM, decompressing the chest if you haven't done already, and screaming for help because you want someone to assess them for a tamponade and do something about it. And this is the time, like was in the discussion before, where you would be thinking of your time for critical care to get to you, or the time for you to get to critical care, or if it's feasible, then arranging a rendezvous with a critical care team on the way to preferably a major trauma centre for children, but they're not as widespread as the adult ones, so you might be just thinking of going to a normal hospital just to get some help. In this child, this is a bit of a picture, by the way, sorry. A thoracotomy was performed by a HEM service. The picture here shows what it looks like to have a thoracotomy. In a child, it looks exactly the same as it does in an adult, and the same things are done and the same approach is used. I'm going to move past that. So the thoracotomy happened and there was a big tamponade for this kid. The clot was removed and bleeding was controlled. So now you're on scene and you need to move on somewhere else. Obviously, this child has had a lot of interventions and needs some specific ongoing care. And so your destination planning is really important. And I keep on going on about children's major trauma centres. There's a million maps. If you type in major trauma centre onto Google, you get a million maps about adult trauma centres. But frustratingly, children's major trauma centres aren't always co-located. There's not as many of them, and there's no maps or anything available to help you find one until we did one on KidConfident. So this QR code, or if you just go to the website and go to the trauma resources, you can find a Google map with all of the UK's children's major trauma centres, and you can even get directions to them if you need to as well. So this is a really important thing, especially for a child who's got severe traumatic injuries, because you want a team who are used to managing them and have the expertise to manage them really, really well. Because just like for you, going to a major trauma in a child is rare, it's really rare for a normal hospital to see a child with significant traumatic injuries as well. So going to the right place is really important, but that does have to be balanced with the resources available on scene and the time for you to get there and the condition of the child. I understand that. Roger says that it's something showing his age. What's showing his age? Told many years ago that reversing hypoxia and identifying it quickly can improve outcomes. Yeah, but children are still the same now as they were in 1992, and that is, as Derek has qualified on there, most cardiac arrests in children are due to respiratory causes. It is because of hypoxia rather than cardiac problems as it is in adults. So addressing the hypoxia can often reverse things, but there are other causes as well, so we do need to look into all of those. Kelly saying Nottingham, then yeah, Nottingham's got a co-located trauma centre for both of them. So if you're in the East Midlands, you go to Nottingham. If you're in North Derbyshire though, you might want to go to Sheffield, and then you have a choice of hospitals, don't you? You have to go to Sheffield Children's rather than Northern General, because they deal with the Sheffield Children's is the major trauma centre there. And I think in Birmingham as well, you have to scratch your brain a bit about which one you're going to go to and which day of the week it is and all those sorts of things. Awesome. We'll do another case if you want. This would be something that is more common than traumatic cardiac arrest due to crush injuries in children, and it's of an 8-year-old kid brought out of the water by his dad, who was found face down on the edge of the water, hadn't been seen for 10 minutes. There's no other history available, and when Mum called 999, there were signs of cardiac arrest, and so she started CPR as directed by the call handler.
Just before we carry on, Adam, talk about fluid resuscitation, optimal blood pressure and trauma, but this doesn't take into account poor neurological outcomes. Is there any guidance on trying to achieve both? It's a really good question, and I think we'll put it out to the team, but I think we've got fluid resuscitation, optimal blood pressures in trauma, ICP and MAP is really, really key to managing that. Oxygenation is also key. So if everything is done well and all the basics are done really well, I think it's probably something that we'd look at secondary to primary. Is that fair, James, do you reckon? You know, we've got to make sure that the kids are perfused. And Derek, yeah, thoughts?
So here's our head injury post on the KidConfident website, and we talk about on this targeting of blood pressure with head injuries, and the general rule of thumb is twice the age plus 70 as a systolic target for blood pressure. A rough rule of thumb is if they're up to 2 years old, systolic of 70, 5 years old 80, and over 10 90, and that takes you into the adult range then, doesn't it, where you have proven worse outcomes with a systolic of less than 90 when you have a head injury. I think like you're saying, though, Gareth, the most important thing is to provide some oxygen and volume with adequate blood to be able to perfuse the brain. And hypotensive resuscitation in children isn't really a thing at the moment, so you can target these blood pressures, but I wouldn't give excessive fluids to try and boost their blood pressure up, because then you do risk blowing clots off and you can settle for lower targets. In a child with polytrauma, you want to be doing the best you can to return circulating volume. If you've got an isolated head injury, then you want to try and target some sort of blood pressure, but importantly you want to make sure their glucose is okay, because children's glucose usage is quite high, so you want to make sure you're checking their BMs and replacing glucose as required, even in the non-diabetics, and making sure that you're getting adequate oxygen delivery to the tissues. Should we go back to the case study? Unless there's any more questions about head injuries, please put them on there. So we've got our 8-year-old child who's been pulled out of the water in cardiac arrest. The CPR has been done by mum as told by the call handler, and the ambulance is just around the corner, so it arrives 4 minutes after the 999 call, and the critical care team is available and is likely to be there within 14 minutes. That's their estimated time. AD has put on there, he's gone straight for it. He's going to go for an ABCDE approach, which I love. And yeah, that's exactly what you do after, of course, scene safety, because you're not going to, in this case, it doesn't matter, but in some cases with drowning in children, you don't want to be putting yourself at risk of drowning yourself. So your primary survey on your ABCDE AD is here. You've got an obstructed soiled airway with water and vomit in it. There's no respiratory effort, unrecordable SATs because of that. You've got a heart rate of 68 on the monitor, but no palpable pulses. So you're in PEA, and you've got prolonged capillary refill time of 7 seconds. Pupils are reactive but slowly, and the BM is 3.8 with a low temperature of 28 degrees. It is cold out at the moment. So what you're going to do is you're going to do your ABCDE approach. You're going to clear the airway. We recommend that you wouldn't move past A until the obstruction is cleared, AD. You're going to clear the airway. You're going to avoid tilting them because when they're in this condition and they're in arrest and from drowning, all of their GI sphincters are open. So actually tilting them can further contaminate the airway because all the stomach contents just come running up. I would have the suction ready, as Kelly said, and I would always administer high flow oxygen. With this child who's got no respiratory effort, I would use the bag valve mask to ventilate them. But if they're not in arrest and they're struggling, I would assist them with a bag valve mask as well if their SATs are less than 90% or if their respiratory rate is out of normal range for their child. If they're hypothermic, then they could be bradycardic, and if that's less than 60, then APLS says that we should start CPR, especially if they're unresponsive. Now, there's a bit of a caveat to that. The Resus Council guidelines of children is anyone under the age of 18, but you could have a 14-year-old, say, who's really fit and plays sports all the time, and you've got a resting heart rate of 58. Now, if they're in front of you, I wouldn't start CPR on them, because if they're responsive, that would obviously be inappropriate. But if they're unresponsive and they've got a heart rate of less than 60, then obviously start CPR, and you'd get your access and give fluids if they're hypotensive as per the guidelines. Children who are cold and adults who are cold as well have got irritable myocardium, so moving them too much is not great for them, and it could put them into an arrhythmia, but that's probably a secondary consideration to be had. You check their blood glucose, and like we just said, they have low glucose reserves, especially in the younger children, so hypoglycemia can happen sooner and needs treating with 10% glucose. And you'd be measuring their body temperature, removing any wet clothing, drying them off, and doing all the good things that you can do to warm them up. So heating on in the ambulance, even if you're going to be too hot, they need the heating on, and use some dry blankets to keep them warm. Then you've got all your considerations for hypothermic arrests. So temperatures below 30 degrees, you wouldn't give any drugs, only deliver 3 shocks, and for children it's 4 joules per kilo. If their temperature is above 30 but below 35, then you double the interval for your drugs and you would defibrillate them as normal. And the best prognosis for hypothermia and for drowning is short time of exposure, no other injuries or comorbidities, a near normal temperature, and a rapid ROSC. And that really goes without saying. A few more questions. So, AD wouldn't have moved past A until the obstruction's clear. That's fair enough, but you can clear that quite quickly, like Kelly's saying, with some suction. Hannah, I-gel and suction via the I-gel, you can do that. If they've got lots of like vomit and stuff, it can be a bit thick. It can be difficult to get through the small suction catheters that you can put down the I-gel. So I would personally just use a Yanker sucker to get out the big blobs. Georgia's asking about giving glucose with a temperature below 30. Yes, you can give glucose. I think so. The don't give drugs thing is really talking about adrenaline, because it has less of an effect with a low temperature. But glucose will help the patient's liver generate heat, and so that would help warm them up, and that would still happen even at a slower rate with a temperature below 30. So definitely you can give glucose with a temperature below 30. Is there an increased risk of laryngospasm? So anything on the larynx, Roger, will increase your risk of laryngospasm. We see that in theatres when they have secretions as well. If they're a bit obtunded neurologically, then anything that touches the cords can put them into laryngospasm. So that goes back to Adie's point and Kelly's point of clearing out the airway using suction, and doing the best job you can with that. Tympanic temperature measurement in patients with wet ears can be very misleading. It can be very misleading, you're right, Jutta, but if that's all you've got available to you, then it's a good marker. I would suggest that you can't do any harm by warming anyone who's been involved with any injuries or has been submersed or immersed in water as well. So I think that's quite a good thing, but yeah, they can be misleading. So there we go, that's our approach to drowning in children, I think. We've spoken about these hypothermia and prognosis, and then we've got back to downloading some free stuff off KidConfident. So that's all good. Now, somebody did ask a question about head injuries and whether here we go, Tay. How does the pathophysiology of head injuries differ from adults? Essentially, it doesn't really. You've got a brain inside a box and it's of a fixed volume. So if you have a head injury, it causes swelling of the brain, or it can cause bleeding, and both those things take up more space than the skull has space for, and that raises your intracranial pressure. So things that you can do to try and reduce that is deliver enough oxygen, deliver enough glucose to the brain tissue, and manage the bleeding as well. So giving tranexamic acid, and you're positioning to promote venous drainage, as Derek was mentioning before, all really important things to do. So I would say that the pathophysiology of head injuries doesn't really differ from adults. Children do have soft fontanelles, so really young children have soft fontanelles, and their sutures, the joints between their skull bones, haven't completely fused, but that's at a really young age, and that can give a little bit more space, but it's not a get out for raised intracranial pressure, and they will still get raised intracranial pressure. And as Gavin's mentioned, the fontanelles can be a useful indicator for raised ICP, but they often have to be quite raised, I would say, for that to be really, really obvious, especially if you've got lots of other things going on and you're examining the child as well. But definitely they can be an indication of ICP. I can't remember the exact age, Derek will say, but fontanelles that can give that much so you can see raised intracranial pressure is in really young kids. So yeah.
Yeah, I was going to say, I was going to just echo what you're saying. A fontanelle can give you sort of like a bulging fontanelle, will give you an indication more in meningitis or something like that, maybe. And when it's all happening acutely like that, it may be bulging, but you can have some more, a very drowsy, floppy, or a child that is obviously well in front of you. The anterior fontanelle is the one that closes. Lastly, you have anterior and posterior fontanelle. Posterior is quite hard to feel. The anterior one is the one you're probably going to see, and that should be closed by 1 year, but starts closing from sort of like 6 months and gets smaller and smaller and smaller until. So I think under 6 months is where you would see something where you could say, okay, there's a bulging fontanelle. But my argument would be that you'll have a sick kid in front of you with a history of probably head trauma that will lead you to more. Although what I would say as well is just from a trauma point of view, the highest cause of traumatic poor outcomes in children is head injuries, and that's in the under 1 years, and particularly in the 3 months group, and that's all from non-accidental injury pretty much. So just be aware of a sleepy child that could be septic, could be, they're tricky, and I've been caught out before, certainly.
I think the take-home message again is that we're using that. We say it a lot, but it's true. Treating the kids like small adults. Actually, it's about the sensible things in the reduced elevated ICPs, the head of the bed at 30 degrees. So when you're transporting them in, if you are using a cervical collar in peds, which you still can sometimes do, just to make sure that it's the neck's neutral and the cervical collars is not pushing down to sort of impede that venous flow up into the brain. And then as things that the enhanced care team and critical care teams might start to bring to the party, particularly in ICU medicine, as we're using the hypertonics, the mannitols and things. And then just looking at, there was a paper going around about hyperventilation, trying to blow off that CO2 pre-hospitally, because it can lead to some increased ICP. That's definitely not anything that, and correct me if I'm wrong, but we're not actively hyperventilating to try and get that CO2 down in respect of trying to manage the ICP. So doing the really simple things well, again, will help the patient's outcome ultimately.
Yeah, I think that's right, Gareth. I think so. The trade-off is a high CO2 will cause vasodilation, and that will increase the volume of blood in the brain, and that contributes to ICP. But hyperventilating them and blowing the CO2 too low causes vasoconstriction, and that will prevent perfusion of the brain, which is just as bad, really. It does say it's stopping blood flow to the brain and oxygen delivery, so that can lead to worsen outcomes. Some people are still advocating using collars in children. Personally, I think there's no place for collars at all in anyone, but that's me.
Yes.
I didn't know that we actually were, to be honest. I thought that was not being used. So it's interesting for me to know. Like I said at the start, I'm learning from you guys, which is really useful.
Oh, collars are bad, man. They're just bad. They cause pressure sores and badness. Yeah. Fine. I think if anyone's got any other questions, then please leave them. Always remember as well that you can ask us questions through our Facebook group, Paediatrics for Paramedics, which is free to join, obviously. And we've got our team, us three and some others, who screen the questions and provide answers for them. You can always send us direct messages through Facebook as well, and we will do our best to answer your questions. And there's a facility on KidConfident as well for you to be able to contact us with any questions or comments and ideas for content topics as well, topic content, something like that. So if there's something that you want to learn about that we haven't covered, or you think is important for you and your colleagues to know about, then please let us know and send us a topic request so that we can try and do some content for you to help out with that. Hopefully you've all found this session useful and you're not laughing too much at my inability to speak or use technology. And I'd like to thank you all very much for coming. And if there's no more questions, I'll say thank you very much. Good night. Is any of the other two, do you want to say anything else?
No, again, thanks guys, just appreciate it, and we really do hope you get a lot from this, because we do as well, so thank you.
Yeah, thank you all very much, and thanks for keeping me honest, Gavin, as well. Mr. Resource Officer, Teacher's Pet, love you. Take care, thank you very much. And the recording for this, somebody's asked if the slides will be available and the recording will be available. We will aim to put it onto the Facebook page on the group as soon as possible. So thank you very much.